Hello everyone, I'm audible. Good evening to all of you. Good evening all. Yes, I can see myself. So, hello everyone, myself Dr. Amit Jain, and today we will be discussing the most high yield points in the biochemistry for the upcoming exam, right? So in this session, what we'll be covering is, first of all, the metabolism section and the most important disorders, right, which are being commonly asked in the exams. So let's talk about the disorders. So I have tried to keep the images here, and we will make some flow charts based on that. Okay, right. So if you have any doubt, any question, then you can just ping here. I can see some of the students here, Arijit, Navina and Tejeshwar. The names I can read. Okay, so let's start without wasting any time. Fine. So see, I know you guys are already motivated, so no need to motivate you right now for any exam, right? 5th March is just around the corner, and so you guys are already motivated, right? So just cap this image for the purpose of motivation. So let's start our first topic. Okay, so in this topic you can see these two images, right? Okay, can you see these two images? So based on these two images, like if I say that there was a patient who presented with a severe sun sensitivity and severe abdominal pain, and the urine was found to contain the port wine colored. So urine was port wine colored. So see, listen to my question again. Severe sun sensitivity plus the port wine color of the urine. So what is your probable diagnosis? Okay, so can you answer this question? Okay, so as you can see, this is nothing but, just a second. So this is severe sun sensitivity, right? And this is port wine or wine colored urine. Okay, so what kind of porphyria it is? So can you answer me? Because both the thing is, like, the patient presented with the sun sensitivity and the acute abdominal pain. So guys, this is the porphyria. Definitely you're right, this is the porphyria, right? But what kind of porphyria it is? So let's take that point. Okay, so let's take that point. So there are three types of porphyria we have. Okay, so whenever there is a MCQ on porphyria, whenever there is a MCQ on the porphyria, what you have to see is, so when you see the MCQ on porphyria, guys, just look at the 2 points. Are there any acute clinical features? Okay, so there is only the acute clinical features, and plus there is no sun sensitivity. Okay, no sun sensitivity. Okay, so can guys go for the answer, that is acute intermittent porphyria. So this will be the answer, acute intermittent porphyria. So whenever there is only acute clinical features and no sun sensitivity, it is acute intermittent porphyria. And commonly the patient has a history of fasting and the drug consumption, which are enzyme inducers. So what are the enzyme inducer drugs that this patient can consume? Like alcohol, barbiturates and steroids. Okay, now guys, the point is that if the patient presents with the acute clinical feature plus sun sensitivity, okay, then what is our answer? So acute clinical feature plus the sun sensitivity. Then there are two possibilities, and this is a case of the mixed porphyria. So the two possibilities that we have is, number one, it is hereditary coproporphyria. Okay, hereditary coproporphyria, right? So that is the one. Okay, so number one, and the second one is the variegate porphyria. Okay, second one is the variegate porphyria. Okay, so now what we have to remember is, like, being a biochemistry student, what is the most important point is the name of the disease and the name of the enzyme. Okay, apart from these 2 points which are clinically important here, nothing else. What is the name of the enzyme here? So obviously you all know what is the enzyme deficient in acute intermittent porphyria. That is PBG deaminase, right? So the name of enzyme is the porphobilinogen deaminase. Okay, so deficient PBG deaminase. In case of hereditary coproporphyria, what is the name of the enzyme deficient? As the name suggests, it is coproporphyrinogen oxidase. So deficient enzyme is coproporphyrinogen oxidase, and in the variegate porphyria, the name of the enzyme deficient is protoporphyrinogen type 9, okay, oxidase. Fine, guys, right? So till now the questions which are being asked in the exams are mostly on the acute intermittent porphyria, but you know, this can be the new point that you may have not noticed, right, in your practice, but you should know this point. So see, I don't want to add something new here. I just the same thing that you have studied, but in a different way, that if the question says both acute and sun sensitivity, then mark these two, right? That is hereditary coproporphyria. So in the investigation, what you will be finding, that in the coproporphyrinogen oxidase deficiency, in the investigation, you will be looking at the question, you will find increase in the levels of coproporphyrinogens in the feces, definitely, right? Copro means feces, and right, urinary porphyrinogens will be missing or very low. And in case of protoporphyrinogen 9 oxidase, obviously the protoporphyrin levels in the urine will be high, right? So increase in the levels of protoporphyrinogen type of the porphyrins. Clear? So that is how you can go with these questions of porphyria. Now if we look at this image, right? So look at this image. This is the image which is again important. So what is your diagnosis if you look at this image? Again, the patient presented with the severe sun sensitivity. It was a baby, newborn child, and the first teeth of the baby appears red. Okay, so guys, what is your answer? The answer is congenital erythropoietic porphyria. What is the name? Congenital erythropoietic porphyria, and this child presents with the erythrodontia, which is diagnostic. Okay, so already part of the MCQ, previous MCQ, that is erythrodontia. Am I clear? Fine. So what is the name of the enzyme which is deficient here? So the name of the enzyme is uroporphyrinogen 3 synthase. Okay, deficient enzyme is uroporphyrinogen 3 synthase, right? So what we have to look at is not all the types of porphyrias, but those which are commonly asked and very important. See, hereditary has not been asked, but it can be the mixed type that can actually make us confuse in the exams, whether it is like, you know, what answer should be there, like acute intermittent or something else. Clear? Guys, this is the test for the porphyria. What are the tests for the porphyria, right? So we have already seen that the urine may be of the port wine color, and especially in the porphyrias which are like acute intermittent and congenital erythropoietic porphyria, or the porphyria cutanea tarda. Right, this is a test which is called as a Watson and Schwartz test. This is the control, and this is the test which is positive. So what's the name of this test that we have to remember? Watson and Schwartz test. Okay, this is a test which gives us the pink color. Fine, and the pink color is observed in case of the positive porphyrinogens in the urine sample. Right, so this may be negative in the other type of porphyrias where there is the urinary porphyrins are negative. Like, you know, if I talk about variegate porphyria, it's mostly in the feces. Copro, hereditary coproporphyria, copro means stools. Clear to all? So that is what we have to remember. Clear, guys? So now next point is guys, just few more points about the porphyrias that we should know. Yes, correct. So some more points about the this topic, that is heme synthesis. So guys, the amino acid that we need for the heme synthesis is glycine. Okay, glycine is the name of the amino acid that is required for the heme synthesis. Succinyl coenzyme A is the intermediate of the Krebs cycle which is required for heme synthesis. Clear? Right? What is the name of the vitamin which is required for heme synthesis? Name the vitamin. So the vitamin which is required for heme synthesis is vitamin B6. And guys, B6 or pyridoxine is very important to activate the enzyme that's called as ALA synthase, which is the rate limiting step. ALA synthase. Clear? And guys, this ALA synthase, how it is regulated, which is also one of the important point as a MCQ, that it is inhibited by the heme, okay, heme, and it is inhibited by the glucose. Very important to remember, glucose. Okay, so glucose is the feedback inhibitor of this particular enzyme that is called as ALA synthase, which is a rate limiting enzyme, and that is why this is one of the therapy during the acute intermittent porphyria if the patient has a history of fasting, right? Okay, so very important point. Fine. Now definitely one more point is that deficiency of ALA synthase can lead to X-linked sideroblastic anemia, right? X-linked sideroblastic anemia. And what will be the vitamin supplement that you can give to treat this? Then again you can start with vitamin B6 supplement, as like this was also the MCQ. Very good. Okay. am I clear? Like here? Fine. Now there is one more important question here, which is one of the most commonly repeated point in the heme pathway, and that is like lead is inhibitor of. So guys, lead poisoning. Lead poisoning inhibits the three enzymes of this particular pathway, right? So what are the three enzymes of this particular pathway? First, ALA dehydratase. So guys, remember lead is inhibiting dehydratase, not the synthase. It is not inhibiting the synthase enzyme, but the dehydratase enzyme. Then the next point is, what is the next enzyme? Next enzyme is the last enzyme that is called as ferrochelatase, right? Ferrochelatase. And the third enzyme which is inhibited by the lead poisoning is coproporphyrinogen oxidase, which is also deficient in hereditary coproporphyria, right? So guys, remember, these are the three enzymes. Two have been already asked in the exams, right? Ferrochelatase being the recent one. Clear? Fine. So that's all about the heme as the pathway, right? So only acute clinical features: acute intermittent porphyria, acute plus sun sensitivity, then you go for only two answers, right? And rest is cutaneous type of porphyrias like porphyria cutanea, tarda, or the congenital erythropoietic porphyria. They are cutaneous type of porphyrias. Rest everything apart from these three that we have discussed. So let's move to our next topic, next point. Fine, right? So guys, look at yes, ALA dehydratase, Tejeshwar, this ALA dehydratase, that is the name of the enzyme which is inhibited by the lead poisoning, not the ALA synthase. Clear? Okay guys, look at this figure. You can easily say this is the figure of glycogen, right? So glycogen is stored in our liver and the muscles, and it is the source of the glucose for the first 12 hours, right? So guys, what are the sources of the glucose for the first, for the first 12 hours? What is the source of the glucose? That is hepatic, only the liver glycogen, right? Liver glycogen. So to maintain the blood glucose levels, right, first 12 hours we need only the liver glycogen. Guys, muscle glycogen is not a source of the blood glucose because of the deficient glucose 6 phosphatase in the muscle. What enzyme is missing in the muscles? Glucose 6 phosphatase. So they are not the source of blood glucose. And guys, then next after let's say 12 hours, so 13 to 17 hours. In 13 to 17 hours, we have both gluconeogenesis plus glycogenolysis. both are 50-50, we can say like that, exactly not 50-50, but yes, the gluconeogenesis is increasing, clear. And after 18 hours, right, more than equal to 18 hours, what happens? The hepatic, very important point, hepatic glycogen is depleted. Okay, hepatic glycogen is depleted, clear, fine. So that is one of the very important point. And now gluconeogenesis is the only source of blood glucose, right? So gluconeogenesis is, which is also occurring in the liver, is the only source of the blood glucose, right? Okay, so gluconeogenesis is the only source of blood glucose. Hope you can see that now, right? Am I clear? Okay. So guys, now if there is an MCQ on the glycogen storage disease, right? If there is a question on glycogen storage disorder, fine, then how to proceed for that particular question? So let's take that, right? Because GSDs are one of the very important MCQs in the exams, right? So guys, let's say if there is a MCQ on glycogen storage disorder that you see in the exams, okay, so MCQ on GSD is there, right? Now the question says that the muscles are involved or the patient presents with exercise intolerance. So patient with exercise intolerance, right, if that is presenting, so that means the muscle weakness. So that simply means that it's not a case of two disorders, that is type 1 and type 6. Okay, so simply rule out type 1, that is von Gerke's disease, and type 6, that is the Her's disease. Okay, so just rule out them, fine, because they do not involve muscles, right guys? What is the name of the enzyme in von Gerke's which is missing? The name of the enzyme which is missing in the von Gerke's is called as glucose 6-phosphatase, which is absent in muscles. So if muscles are involved, it cannot be the von Gerke's disease, clear, fine. Then next point is that if there is glycogen is present in the lysosomes, right, glycogen is found in lysosomes, then there is only one possibility, and that is called as Pompei's disease, fine, Pompei's disease, right? Then if the glycogen structure is mentioned in the MCQ and that they says that it is abnormal glycogen structure, right? So if there is an abnormal structure of the glycogen, okay, there are only two possibilities, right? That is type 3 disease, that is called as the Cory's disease, and Cory's disease is also called as the limit dextrinosis, right? Because they have the glycogen structure which is looking like a limit dextrin, which is like, you know, short branches, clear? They have very short branches. Then if one more point, if they says that there is glycogen accumulated in the liver which has very less branches, so guys, that is a case of Anderson's disease, and in the Anderson's disease there is a deficiency of the enzyme that is called as a branching enzyme. In the Cory's there is a deficient debranching enzyme, clear? So what is the kind of glycogen that you will find here? Amylopectin like, okay? So that is also called as amylopectinosis, clear to all? Fine. So if muscles involved, it's not type 1 and type 6. If lysosome has glycogen, clear-cut answer, Pompei's disease. Type 2, acid maltase deficiency, right? And abnormal structure of the glycogen is a separate MCQ also, that is only found in type 3 and type 4, that is Cory's and Anderson's disease, right guys? And guys, if muscles are the major feature that patient presents with the muscle involvement, then we can go with, most importantly, the two answers are possible, that exercise intolerance is there. So it may be McArdle's disease, that is type 5, and it may be type 7, that is called as Tarui disease, right? So Tarui disease, and this is McArdle's disease. So how will we differentiate between these two? Anyone? How to differentiate between McArdle's and Tarui's in the MCQ? So guys, Tarui's disease, that is type 7, due to the deficiency of PFK1, will also present with, hemolysis, right? Hemolysis is also there. So that's the only feature in the MCQ that can help us in identifying Tarui's disease. Very important point. So guys, now you can solve any question of the glycogen storage disease if you keep in your mind these few points. Clear? So that is MCQs on the glycogen storage disorder. Fine. Okay. So now our next topic is how to approach the question of urea cycle disorder, right? So guys, urea cycle disorder, right, they are also the frequent MCQs, especially in the NEET PG, right? So yes, Dr. Arunav, yes, child, but child in Tarui's disease, you are right, exactly right, but you know, like if the question says that, you know, like the patient age is of, let's say, 10 years or 12 years, right, then it will be difficult to identify whether it's McArdle's or Tarui. So look for hemolysis point or the features of hemolysis, right? Look for that. Fine. So guys, how to approach the MCQ of the urea cycle disorder? Okay. So urea cycle disorder is very simple, right? See, look at this point first. See, this is the urea cycle which has been shown here, right? So what is the name of the rate limiting step? So this is the rate limiting step that is called as the carbamoyl phosphate synthetase 1. So in the MCQ, if there is only one thing is mentioned, that is there is high ammonia levels, right? Okay, so that is the type 1 hyperammonemia. Okay, so type 1 hyperammonemia. So there is only increase in the ammonia levels, and the what is the marker of ammonia? Glutamine levels, right? So we can also say that this is a case of type 1 hyperammonemia, right? Whether it's a case of high ammonia levels or high glutamine levels, right? High glutamine levels. So that is type 1. Then we have the type 2 hyperammonemia. So this is a second enzyme, right? Second enzyme is called as ornithine transcarbamylase, right? Ornithine transcarbamylase. So guys, if ornithine transcarbamylase is deficient, the carbamoyl phosphate will accumulate, right? And this carbamoyl phosphate will enter the cytoplasm and converts into the pyrimidine, that is orotic acid or uracil. Fine. So in the MCQ, where there is a child, newborn child presenting with the encephalopathy because of hyperammonemia, right, and they are asking a question on urea cycle defects, and the MCQ says that there is only high levels of ammonia, go for type 1. Clear? And then the type 2 hyperammonemia, HA I am writing hyperammonemia, then what, how will you answer it? That question says that there is increase in the ammonia levels, plus there is increase in the levels of orotic acid, which is nothing but, you know, the precursor of uracil, okay, in the pyrimidine synthetic pathway. Clear? So this is the type 2 hyperammonemia that you can proceed with as the answer. Now rest are very simple, only simple if you remember cycles, right? So you have to remember the urea cycle. Guys, there are only two cycles that we have to remember, okay, that is Krebs cycle and urea cycle. Rest are not required, like whole pathways we are not supposed to remember, as you must be knowing, right? Nobody is asking you the steps of a pathway. But here why it is important, because we can answer the MCQs if we remember the cycle, right? So let's say type 1 and type 2 are the most commonly asked in exams, but let's see if there is a question that says citrulline levels are very, very high. So that means arginosuccinate synthetase is deficient, okay? So that's a disorder that is called as citrullinemia. Fine, citrullinemia. Clear to all? And then next is arginosuccinate acid urea. So if this enzyme is missing, that is arginosuccinate lyase, then arginosuccinate acid urea. Fine. Okay, and if the next enzyme, that is arginase, is missing, then this disorder is called as hyperargininemia. But in this case, there will be no ammonia toxicity because arginine is an like amino acid which is highly soluble in water. So the arginine levels may accumulate, but obviously it is far away from the first step, that is ammonia. So there is no hyperammonemia. Clear to all, guys? So this is how we can answer the MCQs of urea cycle defects, right? Okay, mostly type 1 and type 2 have been asked till now, and it is very easy to identify. If you remember, orotic acid also, orotic acid urea plus hyperammonemia is type 2. Okay, guys, fine. So that is all about the urea cycle disorders for the MCQ purpose, right? Otherwise, guys, what is the rate limiting step of urea cycle? It is the CPS1, right? And what is the activator of CPS1? That is also called as the obligate allosteric activator of the CPS1. Okay, so that is called as N-acetyl glutamate. Fine. N-acetyl glutamate is the obligate, so this is a word that you should know, obligate allosteric activator, okay, of the CPS1. Obligate means there is no activity without the presence of N-acetyl glutamate, that is NAG. Guys, can you name me one more obligate allosteric activator? There is one more that we have to remember, only two names, that is called as the acetyl coenzyme A. So in the gluconeogenesis, right, in the gluconeogenesis, fine. So in the gluconeogenesis, acetyl coenzyme A is something which is activating the enzyme that is called as the pyruvate carboxylase, which is a rate limiting step. Clear? So these are the two examples of obligate allosteric activators of any enzyme that we have to remember, right? So that is definitely the allosteric activator, but obligate. Now guys, let's move to our next point. Okay, so look at this figure that is probably known to you, right? So look at this figure. So can you tell me that in the investigation, what will be the name of the lipid which is being accumulated? So what is the name of the lipid which is accumulated here? So answer is chylomicrons. Clear? So suppose a child is presented with acute pancreatitis. Okay, so this is a case of type 1 hyperlipidemia, right? Type 1 hyperlipidemia. So guys, type 1 hyperlipidemia, there is a deficient LPL or ApoC2, right? LPL or the ApoC2, and because of this, you know, the chylomicrons are not degraded, so there is a high level of chylomicrons. So we can also call this condition as hyperchylomicronemia. Fine. And because of chylomicron levels are high, the TG levels, okay, TG levels will be high, almost more than 1000 mg per dl, right? And that causes acute pancreatitis of this patient, right? Yes, very good. And okay, so TG levels are very high here, but normal levels of cholesterol are present. Fine. So that is called as type 1 hyperlipidemia or type 1 hyperlipoproteinemia. Okay, so if you find a question, acute pancreatitis, milky plasma, right? So this is called as milky plasma, which may be seen also in other conditions like in the severe uncontrolled diabetes, right, where the TG levels are very high in the blood. Okay, so milky plasma is the answer. Clear? So this image plus high TG, normal cholesterol, acute pancreatitis. So what is your answer? Type 1 hyperlipidemia, deficiency of lipoprotein lipase. That is the type 1. Then we have the next type. Okay, so one of the important feature of the next type is that is called as type 2. Okay, type 2 hyperlipidemia or hyperlipoproteinemia. that is also called as familial hypercholesterolemia, okay, which is very important for the exams. Familial hypercholesterolemia, there is a deficiency of which particular protein here, that is called as LDL receptors. So because of this, the total cholesterol levels may be around or equal to more than 500 mg per deciliter, but normal TG levels are present. See, in the type 1 TGs are high, in the type 2 TGs are normal, right? Cholesterol is very, very high. Because of such a high amount of cholesterol, this patient most commonly presents with premature CVD or history of premature CVD, right? Okay, on the examination you will find Achilles tendon xanthomas, which are very, very important, almost pathognomic of type 2 hyperlipidemia. Fine. Is it clear? So that is the history of premature cardiovascular disease. So that is type 2. What are the other causes of type 2? Fine. What are the other causes of type 2 that you will find? The mutant, okay, mutant ApoB100, which is not binding to the LDL receptors, and the third point is that there is overactive, okay, overactive PCSK9 enzyme. So PCSK9 enzyme degrades the LDL receptors in the lysosomes. Clear to all, guys? So that is type 2, right? Then we have the next one. So guys, what is this finding is shown here? What is this finding shown? This is the finding which is called as the palm crease xanthomas, okay, or the Palmer xanthomas we can say, which is a very severe condition here as shown in the figure, right? Palmer xanthomas. Fine, guys. And see, in this case, this is pathognomic of type 3 hyperlipidemia, okay, and in the type 3 hyperlipidemia there is ApoE2 expression. Very good, okay, Dr. Arunav, ApoE2 expression is there. Fine. So in the type 3, fine. So what is the problem with the ApoE2 is that ApoE2 doesn't bind to the remnant receptors, okay. So because it is not binding to the remnant receptors, there will be increase in chylomicron plus increase in VLDL remnants, okay, remnants after their partial digestion by the lipoprotein lipase. These remnants will stay because they are not taken up by the remnant receptors in the, let's say, liver, right? Okay, and guys, because of these remnant receptors, there will be appearance of the broad beta band on the electrophoresis, right? So you can see this, this is the normal beta band, black color here, and this is the broad beta band here. Fine, broad beta band here. Fine, guys. So this is type 3 hyperlipidemia. Till now not a common question. Type 1 and type 2 are being very common till now in the MCQ, but yes, remember type 3 also. So guys, E2 is abnormal. So what is a normal E? E3. And what is the importance of E4? Increased risk of Alzheimer's disease. So you just remember that the normal, what is a normal E? Normal E is actually E3, right? E3 is a normal E. Clear to all? Now look at this picture. So which type of lipid disorder I am talking about? Can you answer me here? What is the type of the lipid disorders that we are talking here? Any answer? Yes, very good. So guys, this is acanthocytosis, okay. So this is a acanthocyte that you can easily identify, nothing like not a big deal for you guys, right? Fine. But what is this disease? This is a disease that is called as A beta lipoproteinemia, okay, A beta lipoproteinemia. What is the name of the protein which is defective here? MTTP, microsomal TG transfer protein. So guys, in this case, what will be the case here? The case will be, because MTTP is required for chylomicrons and VLDL synthesis. So the TG levels of this patient will be almost 0, or maybe up to just, in case of decreased activity, 20 mg per dl, right? That is very less, okay. And cholesterol is also less because LDL which is carrying the cholesterol, LDL is made by VLDL, but there is a problem in the making of VLDL here, right? Because MTTP is not there. So the cholesterol levels are also very less, that is less than 50 mg per dl, right? Normally is like less than 200, but less than 50 is very low. Clear? Fine. So that is the point. And guys, because chylomicrons are not formed, this baby will present with fatty stools and severe depletion of all the essential fatty acids, which causes the formation, malformation of the RBC membrane, that is called as acanthocytosis. Okay, and severe depletion of all the vitamins which are fat soluble. Okay, so ADEK depletion, right? Okay, so that is the A beta lipoproteinemia due to deficient MTTP. And investigation, I believe what you should be able to remember is that TG levels are almost 0. Okay, and the presence of acanthocytes and fatty stools and all the fat soluble vitamin depletion and essential fatty acid depletion. Clear to all? Right, guys? Okay, so this one is something that you can easily identify, right? So this is a case of a disease in which the LDL levels, HDL levels are very, very low, right? So next two questions, the low HDL levels, and this is a case which is called as, what is your answer? You can easily identify, that is called as the Tangier's. Very good, Tangier's disease. Okay, so this is Tangier's disease, and this is due to the ABCA1 deficiency. Okay, ABCA1. So guys, what are the proteins involved in reverse cholesterol transport? So definitely answer is HDL. Apart from HDL, what are the other proteins which are participating in reverse cholesterol transport? So answer is ABCA1 and the LC80 enzyme, right? LC80 enzyme. So the reverse cholesterol transport, we need certain proteins. What are the names of proteins? That is ABC proteins, that is ABCA1, then we have LC80, and definitely HDL is there. Okay, so these are the three proteins required in reverse cholesterol transport. And the patient here presents with orange colored tonsil, as you can see. So the HDL levels are very, very low, that is less than 10 mg per deciliter. Normally they should be more than 40. Okay, so less than 10 mg per deciliter. So that is called as a Tangier's disease. Fine, right? So the next point is, as you can see this image, right? So guys, obviously if you look at this image, you may confuse, like, this may be something, which is like not very difficult to identify. You may think of this as a Kayser-Fleischer ring, like, but this is not that. So what is your answer here? The answer here is that this is the patient, right, who is presenting. Obviously, when we look at the theory of the question, they will mention that HDL levels are less than 10 mg per dl, right? So this may be a case of, the two disorders that I can say. First of all, there is a disorder that is called as Norum's disease, which doesn't present with such clinical features actually. NORUM, Norum's disease. So this is due to 100% deficiency of LC80, right? Okay, and this patient presents with the low HDL, that is less than 10 mg per dl of HDL. Okay, and this is also presenting with hemolytic anemias and renal failure. Okay, so one of the feature is hemolytic anemia plus the renal failure, but this point has never been asked. So this is the case that we are talking about. Is this case is fish eye disease. Okay, fish eye disease. So there is a clouding of the cornea at the limbus, right? So this is a partial LC80 deficiency. This is also presenting with less than 10 mg per dl of the HDL. So guys, such conditions we can call as hypo-alpha lipoproteinemias, right? Hypo-alpha lipoproteinemias means alpha lipoprotein is HDL. Okay, fine. So that is your LCD deficiency, less than 10 milligrams per deciliter. Clear? Guys, there is also high level of VLDL. So VLDL is also increased apart from low HDL. And that you can think of why, because HDL is something which is providing the proteins for the metabolism of VLDL, let's say. This is one of the reason that may increase the levels of VLDL. What are the proteins provided by HDL? ApoC2, for example, is provided by HDL for the lipoprotein lipase activity, which degrades the VLDL. But this is like, not the only cause which increase the VLDL. So we are not going into details of that. But yes, you should be able to answer the two disorders which are of low HDL. First is Tanger's, second is Fish-eye disease, and LCAT and ABC1 are also part of the which type of pathway, that is reverse cholesterol transport by the high density lipoproteins. Clear to all, guys? Okay, there is one more thing here. You should know about the Fridwold's formula. What is Fridwold's formula? Though it has been asked only once in exams, but you should be able to answer. Fridwold formulas is for calculation of the LDL. Okay, Fridwold's formula. Okay, that is for LDL calculation, and it is equals to total cholesterol minus the sum of HDL plus TG divided by 5, right? Okay. Kirti, the session PDF you will get on the telegram channel of the Island Next. Clear? So HDL plus TG divided by 5. Is it clear, guys? So that is the Fridwold's formula used for the LDL calculation, right? Okay. Next time when you see the blood report, just find it. The LDL is written like LDL calculated, right? Okay. Now next point is that MCQ. If you see any MCQ in which they have mentioned that the lysosomes are engorged with a particular material. Okay, so that is a case of lysosomal storage disease, which nowadays are very common questions in exams. So lysosomal storage disorders, what we have to look for the accumulated material in the lysosomes. So that can be number 1, okay, mucopolysaccharides, right? Like for example, heparin sulfate and dermatan sulfate, right? Heparin sulfate plus the dermatan sulfate. So if you see that, then that is a case of the Hunter's or Hurler's disorder. Like for example, the two common names that we should know is Hunter's and Hurler's. So first of all, I am looking at what is accumulated material here. So it may be mucopolysaccharides, it may be glycogen like in Pompey's, it may be cholesterol esters, right? Okay, cholesterol esters, or it may be the sphingolipids. So we have the various names of sphingolipidosis here, right? So first of all, let's say this is the complete corneal clouding. So we have the two important MPS. Guys, see, the list may be very long, but these two you must know, right? So these two are the only questions which are repeated till now in exams. So MPS 1 is the Hurler syndrome. Okay, that is called as the Hurler syndrome. And Hurler syndrome, there is a deficient enzyme that is called as alpha L iduronase. So I am just writing iduronase, which degrades the iduronic acid containing the mucopolysaccharides. So there is heparin sulfate plus dermatan sulfate. These are the only two mucopolysaccharides or glycosaminoglycans which contains iduronic acid. Okay, so they will accumulate in the lysosomes. Don't forget where they are accumulating, lysosomes, because lysosomes are the site of degradation of the various components of our cell, like maybe protein, lipids, or sugars, or like sugars, mucopolysaccharides. Okay, so that is called as a Hurler syndrome, right? And the Hurler syndrome present with the complete corneal clouding. As you can see here, the corneal clouding is there, and they also present with, when the macrophages, they accumulate the same mucopolysaccharides, they are visible as the Elder-Rayleigh bodies. Okay, Elder-Rayleigh bodies. So this may help us in the MCQ. Otherwise, the most important point is the name of disease, name of enzyme, right? And what is the name of the what is the name of the component which is accumulated in the lysosomes? That is most important. Clear, guys? Okay. So MPS 1, then we have MPS 2. Okay, MPS 2 is called as the Hunter syndrome. And in the Hunter syndrome, there is deficiency of the enzyme that is called as the iduronase sulfatase. Okay, so deficient enzyme is iduronase iduronate sulfatase. Okay, guys, this is the only disease, Hunter syndrome, which is X-linked disease. Okay, X-linked recessive, so boys are affected, and there is no corneal clouding, right? No corneal clouding. Clear? So in the Hunter syndrome, there is no corneal clouding. Yes. Very good. I'm getting the answers here. That's really nice. Okay, so you guys are prepared. You know, I can see that. This is just a kind of short, quick, high yield revision for you guys. Okay, so right guys, so type 1 and type 2, you know, that must be known to you. Okay, and you know guys, these mucopolysaccharides or lysosomal storage disorders, they can be treated by the enzyme replacement therapies. Okay, enzyme replacement therapies. Now guys, next is glycogen, right? So what is the name of the disease in which the glycogen accumulates in lysosome? So I told you already, that is Pompey's disease, that is type 2 glycogen storage disease. Okay, type 2. Now cholesterol esters accumulate in a disease that's called as Wolman's disease, right? Wolman's disease, we can see if you have not noticed, during the LDL metabolism. So during the LDL metabolism, when the LDL is endocytosed, it is degraded with the help of a enzyme that's called as acid lipase. Okay, acid lipase. Fine. And in the type 2, what is the name of deficient enzyme? That is called as acid maltase. Fine. Acid maltase in the type 2 GSD, that is Pompey's, and here it is acid lipase. Yes, Tejeshwar, yes, correct. Adrenal calcification, yes, correct. Very nice. You know, way beyond, you know, so you have grip over the subject. That's really nice to see that. Fine. So keep that, continue, keep this fire, continue till 5th March, right? Okay, this right now there is no time to sit back and relax. I mean to say, like, you are not doing that already, but yes, you are motivated. I am not motivating you. I am not trying to do that, right? Okay, so fine guys, that's sphingolipidosis. Now if the sphingolipids are accumulated, see guys, sphingolipidosis, again, what you have to remember is only 3 points. Name of disease, definitely. Apart from that, name of enzyme, name of accumulated material, and the third one is what is the unique point, what is the unique histopathological examination point. Clear? So for example, you can see this image, right, which is definitely difficult directly to identify, but this is the image. Okay, in this case, this is Niemann-Pick's disease. Okay, Niemann-Pick's disease. In the Niemann-Pick's disease, there is a deficient enzyme that is called as the sphingomyelinase. Okay, no, this is not crumpled, this is not Gaucher's, I'm sorry guys, Avantika, right? Sphingomyelinase is the name of the enzyme here. So what is the name of lipid? Okay, lipid accumulated is sphingomyelin. So what you have to remember, what's the name of lipid accumulated? See guys, you know, when the question starts with lots of clinical points and that I'm unable to recall, it's fine. Ultimately what I remember is, okay, that they have mentioned that in the lysosomes there is accumulation of sphingomyelin lipid or the sphingophospholipid. Okay, this is the only sphingophospholipid having phosphate. Okay, so sphingomyelin accumulation is there, and on the histopathological examination, see, this is looking like a foam cell, right? Foam. So soap bubble appearance of histiocytes or the foamy histiocytes, right? So this we can call as soap bubble or foamy histiocytes. So this is not crumpled tissue paper appearance. So no problem. Yes, foamy cells. Very good. Fine. So that is what we can see here. So that is a Niemann-Pick's disease. Fine. Now you can see here, this is already mentioned here in the right hand side, that is called as the Gaucher's cells. Right, in the left hand side also, see, it is no doubt not easy to identify, right? Okay, but they can, this is the one that we should remember, right? because this is the one which have been asked several times in exams. Okay, so guys, this is called as the Gaucher's disease. What we have to remember is the name of the deficient enzyme, that is called as a glucocerebrosidase. Okay, glucocerebrosidase is the name of the enzyme. And what's the name of the lipid accumulated? Obviously the glucocerebrosides, which contains glucose, glucocerebrosides. Yes, that's okay. So lipid glucocerebrosides are present here. Fine. Okay. And what is a special feature of the Gaucher cells that you all know? That is a crumpled tissue paper appearance, right? Don't forget that, wrinkled or the crumpled tissue paper appearance of the cells of the histiocytes. Okay, guys. Okay. Also, just one more point. In this case, the femur appears like the test tube in the lab, and that is called as Erlenmeyer flask deformity. Okay. So what do you call this? This is called as Erlenmeyer flask deformity because of the broadening of the metaphysis of the femur. There is Erlenmeyer flask deformity. Clear? Now moving to the next point. So this is the image which is like onion skinning of the lysosomes, and this is seen in the Tay-Sachs disease. Okay, or this may be seen in the Sandhoff's disease. So guys, in the Tay-Sachs disease, the name of the enzyme deficient is called as hexosaminidase A, right? Hexosaminidase A, and this is called as the onion skinning. Yes, very good. Onion skinning of lysosomes, right? Okay, so this may also be seen in the Sandhoff's disease. So how to differentiate Tay-Sachs from the Sandhoff's? Okay, the name of the lipid is helping us to identify the disease. So in this case, GM2 ganglioside, right? GM2 ganglioside is the name of lipid which accumulates. While in the Sandhoff's disease, there is a deficient hexosaminidase A and B both, and there is accumulation of the lipids which is called as GM2 ganglioside plus there is also the accumulation of globoside. Okay guys, so this can help us if there is a question and you see the question, this image, and there is no Tay-Sachs mentioned, then go for Sandhoff's, and if both Sandhoff's and Tay-Sachs mentioned, then look for the point, that is this point. Am I clear? Right? And remember guys, GM1 ganglioside is required for the receptor of cholera toxin, GM1. Clear? Now this is the image which shows us the angiokeratomas. Okay, so where you see angiokeratomas, this is the image where you see a specific eye finding in the Fabry's disease, that is corneal verticillata, right? Corneal verticillata. This is the image that is called as the mulberry cells, right? When seen under the microscope, the urine was seen under the microscope, so there is a lipiduria, and these lipid droplets, they are basically, they contains the lipid accumulated distal tubular cells which are known as mulberry cells. So these are diagnostic. Okay, these are diagnostic. So guys, Maltese cross, yes, someone has written Maltese cross, but this is Maltese cross, as you can see, right? This cross is called as Maltese cross, but this is not specific for this particular disease, but yes, this is a famous sign for this disease and already part of MCQ, Maltese cross. So this was due to the birefringence of these mulberry cells or the lipid droplets under the polarized microscope, dark field polarized microscope. Clear guys? Okay, so these are all the lysosomal storage disorders that you should be able to identify and answer in the exam. So again, I am repeating, look for name of disease, name of lipid, name of enzyme, and one key point, right? So just revise only these 3 points apart from name of disease. Am I clear? Right? If you remember this, you will always be able to answer the question, even if you know nothing about a clinical point, clinical feature. Okay, fine. Now guys, MCQs on the fatty acid oxidation defects, right? So when there is an MCQ on fatty acid oxidation defect, how you have to proceed, right? So there are 3 disorders or the 4 disorders that we can take here. So first is guys, alpha oxidation, right? Okay, so there is a disorder that is called as a Refsum's disease, right? Refsum's disease is due to alpha oxidation defect, okay, and there is accumulation of the phytanic acid, which is a type of branch chain fatty acid, right? Alpha oxidation occurs in peroxisomes. What is the site of alpha oxidation? Peroxisome. So this is, we can say, is a peroxisomal disease, right? So alpha oxidation defect, accumulation of branch chain phytanic acid, fine, and there are some clinical features like retinitis pigmentosa and polyneuropathies, fine. So that is alpha oxidation we do for phytanic acid. Then moving to the beta oxidation. Now in the beta oxidation, when we talk about beta oxidation, there are 2 disorders, fine. First is MCAD deficiency, right, which presents with non-ketotic hypoglycemia. So what are the 2 investigations that are very important to remember? Non-ketotic hypoglycemia. Guys, no condition in the medicine apart from excess insulin dose or insulinoma, right? I mean to say excess insulin presence. So no other condition apart from that can cause non-ketotic hypoglycemia. So this is the only answer, right? Okay, unique point, non-ketotic hypoglycemia. And guys, because of the defective beta oxidation, right, there is omega oxidation in the smooth endoplasmic reticulum, right, and this will produce dicarboxylic acid urea, which is again very important name and diagnostic of beta oxidation defects, okay, beta oxidation defects. Carnitine acyl transferase is a rate limiting enzyme. Yes, for beta oxidation, yes, correct. Carnitine acyl transferase 1, not the 2. CAT1, if you want to remember the rate limiting enzyme of beta oxidation, that is CAT1. Okay. So guys, omega oxidation occurs in smooth endoplasmic reticulum when? Only in the defective beta oxidation. So right now a normal person is not doing omega oxidation, clear? So dicarboxylic acid urea is present. So guys, 2 features that you must know in the beta oxidation defect investigation for the MCQ is non-ketotic hypoglycemia and the second is dicarboxylic acid urea, nothing else. If you remember these 2 points, you are done with the MCQ, right? Okay. Now very long chain fatty acid, right? Very long chain fatty acid, guys, they will be deposited in a condition that is called as the Zellweger syndrome. Okay, so Zellweger syndrome, and Zellweger syndrome is also called as cerebrohepatorenal syndrome, and there is a complete absence of peroxisomes. Okay, so peroxisomes are absent, right? The other name is cerebrohepatorenal syndrome, and that is why the very long chain fatty acid accumulates in the tissues. Okay, so again I am repeating, if it's a Refsum's disease, phytanic acid accumulation will be mentioned. If it's a Zellweger syndrome, very long chain fatty acid accumulation plus the absence of peroxisomes will be mentioned in the MCQ, or that may be the answer. And if it's a defective mitochondrial beta oxidation, because the very long chain fatty acid oxidation also occurs in peroxisomes, right, not in the mitochondria. But MCAD or the medium chain or the long chain fatty acid oxidation occurs in mitochondria. So if that is defective, we have 2 points to remember. One is non-ketotic hypoglycemia and the second is the dicarboxylic acid urea. So now you can go with these 3 questions, right, easily. All 3 are important: Refsum's, Zellweger, MCAD, even dicarboxylic acid urea, and even the omega oxidation was a recent one. Clear to all, right? So now guys, very simple points but very commonly repeated in NEET PG, especially the products of amino acids. So I am just writing here, filling the blanks. Tyrosine, right? So you can keep on telling me in the chat box. So tyrosine, actually guys, remember one more thing, carnitine is not required for the oxidation of medium chain fatty acid, only for the long chain, not even for very long chain. Carnitine, which is a dipeptide made of lysine plus methionine, is only required for the oxidation of long chain fatty acids, not for the other fatty acids. Clear? Okay. Tyrosine. So what is the product of tyrosine? The product of tyrosine is, guys, the thyroid hormones like T3 and T4. Fine. Then what else? Catecholamines. Okay. Catecholamines, and definitely very important is melanin. Right. Arginine, nitric oxide. Histidine, histamine. So can you tell me the names of enzymes also? Histidine decarboxylase, right? Anosynthase. Glutamic acid decarboxylase produces GABA, right? Decarboxylation requires which vitamin? B6, right? Decarboxylase is a group of enzymes, right, which requires vitamin B6, and carboxylase requires biotin, right? So tryptophan, what are the products of tryptophan? There is melatonin, there is serotonin, okay, and definitely the one which is called as niacin. Okay, 60 milligram of niacin produce 1 milligram, 60 milligrams of tryptophan produce 1 milligram of niacin. Clear? So glycine is required for the production of heme, right? It is required for the production of collagen. It is required for the production of adenine and guanine, but not cytosine and uracil, means not pyrimidines. Okay. So guys, remember this, that purine synthesis need glycine but not the pyrimidine synthesis. And it is also required for synthesis of glutathione. And it is also required for synthesis of creatine, right? Creatine and glutathione. Okay. So very important, glycine also. Glycine is actually, most of the time it is missed, right? So don't miss it. Glycine is very important here. And serine, guys, serine is required for the synthesis of sphingosine, the alcohol that is required for synthesis of sphingolipids. Methionine is directly not required, but it is producing SAM, S-adenosyl methionine, and SAM is a very important methyl donor, for example in converting norepinephrine to epinephrine or the serotonin to melatonin, right? So SAM is very important. Yes, purine is required. Dr. Obito, correct. Fine guys, so that is amino acids, products which are very important. Now in terms of disorders, PKU have not been asked for the long time, and this may be the question again, right? PKU, phenylketonuria. So phenylketonuria is the disease in which the name of the enzyme deficient is phenylalanine hydroxylase, or the coenzyme which is tetrahydrobiopterin may be deficient, and that is called as a malignant PKU due to the deficient dihydrobiopterin reductase actually, but BH4 is not synthesized or regenerated. Okay, the patient has mousy or musty odor due to the phenyl acetate. Don't forget that phenyl acetate. The diet is phenylalanine restricted, but the tyrosine becomes conditionally essential. So don't forget that tyrosine is now conditionally essential. Also, like the cysteine becomes conditionally essential in homocystinemia, right? Because that is not produced. Now, the latest drug which is used in this disorder is known as Palynziq, which is actually the name phenylalanine ammonia lyase. So this can be a new point in your MCQs, right? Clear? So phenylketonuria, this much you should know, right? These are the high yield points that are related with this topic, PKU. Now looking at the next amino acid, that is tyrosine. Guys, tyrosine is having three disorders, right? Number one is type 1 tyrosinemia. Type 1 I am discussing, not type 2 and type 3. Type 1 tyrosinemia is most common due to the deficient fumarate acetoacetate hydrolase. Okay, that's the name of the enzyme. And succinyl acetone is the marker which is produced from fumarate acetoacetate, which is a metabolic toxin causing hepatorenal failure and hepatocellular carcinoma. Okay, and the patient has a boiled cabbage body odor. So guys, odors may be important, right, in diagnosing the MCQ directly, even without knowing any other point, right? So odors are always very important, like boiled cabbage odor. But guys, again, let me tell you, don't forget the name of enzyme. That is the most important. Okay, because I can say tyrosinemia has been asked 10 times, but every time I will say that question is same, and that is the name of enzyme they have asked, right? So put your focus in remembering that thing, not any unnecessary things, not any unnecessary clinical picture that is actually will not be asked in exams. And even asked, ultimately they will assess you whether you remember the name of enzyme or not. So definitely we need a little more cautious about it, that we should be able to remember the name of enzymes or some key point, not everything, but any key point which may help in direct, like this is the key point, boiled cabbage body odor. Clear guys? Next is L-captonuria, that is one of the favorite. Homogentisic acid oxidase is the name of enzyme. So the urine contains large quantity of homogentisic acid, and which turns black on the air exposure, that we all know. This is the unique point. Okay, and this will also deposit in the tissues, that I will show you. Vitamin C is used as a therapy because this is antioxidant, okay, preventing the damage to the joints because of homogentisic acid accumulation. And guys, the last one is albinism. Albinism, and the name of the enzyme which is deficient is tyrosinase, right? Tyrosinase. Clear? Fine. So look at this point. This is the case of L-captonuria, right? L-captonuria. So there is a darkening of the skin, right? Of the darkening of the sclera, right? Urine turns black, and see guys, these are tyrosine crystals. Tyrosine crystals looks like the needles, okay, when they are seen under the microscope. So the bundle of needles, right, as you can see that if mentioned in the MCQ, right? So like in the cystinuria we have the crystals which are hexagonal. In tyrosinemia we may have crystals which looks like these needles, okay, like this. Fine guys. Okay, yeah, this is also called, very good, this is also called as ochronosis. Guys, this is called ochronosis because of the ochre colored staining of the dermal fibers seen under the microscope. Ochre color, that is yellowish brown color. Clear guys? Moving to our next point, that is next amino acid, branch chain amino acids. Guys, branch chain amino acid, the disorder that we have to remember is maple syrup urine disease, very common one. The name of enzyme we all know is BCAA alpha ketodehydrogenase. Okay, guys, the same enzyme as of PDH, right? It is doing oxidative decarboxylation. So we need the same 5 coenzymes as of PDH. So what are the same 5 coenzymes? Thiamine, riboflavin, niacin, pantothenate or the coenzyme A, and the last is lipoic acid, which is non-vitamin. Okay, burn sugar order, definitely we all know. Allo-isoleucine is the marker, okay, on the mass spectrometry. So guys, what is our test of choice or technique of choice for the investigation of any inborn error of metabolism? Your answer is mass spectrometry. Very important question. Any inborn error of metabolism can be screened or diagnosed or investigated using this technique, using this advanced technique. Clear guys? Fine. Leucine is the, some more points about the branch chain amino acid, like leucine is a purely ketogenic amino acid, right? And HMG coenzyme is a intermediate in the pathway, just like the cholesterol and ketogenesis. So what are the 3 pathways which has HMG coenzyme A as a common intermediate? Leucine, cholesterol and ketone body synthesis. Clear? Okay, HMG coenzyme A, right guys? Then there is a disorder which is called as isovaleric, it's not visible here, isovaleric acidemia, right? And isovaleric acidemia is having a special point that we have to remember, that it is having deficiency of the enzyme that is called as isovaleryl coenzyme A dehydrogenase. What's the name of disease? Isovaleric acidemia. Okay, name of enzyme is isovaleryl coenzyme A dehydrogenase, and this patient presents with the sweaty feet body odor. Isovaleric acidemia, sweaty feet body odor. Clear? Fine. Segawa syndrome is is not required. It is one of the rare disorder linked with the this PKU and all. So leave that. That is not required here. Okay. Next is tryptophan. Tryptophan is a very important amino acid. Tryptophan, we have the first thing. Okay, guys. One more thing is fine. Okay, tryptophan is Hartnupp's disease or pellagra-like dermatosis, right? Pellagra-like dermatosis. So neutral amino acid transporter, guys, please don't forget this name, SLC6A19, solute carrier 6A19. Clear? So there is a defect in both kidney and intestine. So this solute carrier is present in both kidney and intestine. So the tryptophan is not absorbed and it is excreted in excess. All the neutral amino acids are excreted. See guys, except the acidic and basic amino acid, all other are neutral amino acids. So except the arginine, lysine, and if we talk about acidic, glutamate and aspartate. So except these four, most others are neutral. Okay, kind of neutral amino acids, but tryptophan excretion is high, so there is a low niacin synthesis. So the patient presents with pellagra-like dermatitis, very important name. Okay, so it's a kind of a skin rash which appears on the sun exposure and which responds to niacin therapy, right? So the baby present with the skin rash after the sun exposure. That is actually kind of sun sensitivity, which looks like the case of pellagra, and it is actually responding to niacin. So it is a kind of pellagra-like dermatitis. Clear, guys? Now, very important again, trimethylamine has been asked previously in NEET PG and later on fish order syndrome. So both are same, fish order syndrome or trimethylamine urea. Okay. So what is the name of the enzyme deficient here? Flavin monooxygenase 3. FMO3. So guys, this is due to the consumption of choline, right? So choline is degraded to the trimethylamine, and which has a rotten fish odor, and this enzyme remove the trimethylamine from the cells from the in the liver, right? So the only therapy, which was a recent question, is choline restriction. So fish order syndrome, how we can treat it? By the choline restriction. Like what is the treatment of the maple syrup urine disease? Restriction of the valine, isoleucine and leucine. Right? What is the treatment of PKU? Restriction of phenylalanine, because they are all essential amino acid. Right? Okay. So choline is also essential nutrient, not the amino acid, but yes, nutrient. Now guys, methionine has three important points, that is classical, non-classical homocysteinemia first of all. So classical homocystinuria and non-classical, how to differentiate? So guys, in the classical, cystathionine beta synthase is the name of the enzyme which is deficient. Fine. So there is a high level of both homocysteine and methionine, right? You know why? Because the excess homocysteine will be converted to the methionine using the enzyme methionine synthase, and which is B12 and folate dependent, right? So whenever the homocysteine levels they increase, they will also make methionine, so both the levels will increase, and that is the diagnostic point in classical homocysteinemia, right? Okay, what is the treatment you will give? Already important MCQ. Vitamin B6, because it is the activator of cystathionine beta synthase, may help, and cysteine is called as the conditionally essential amino acid here, right? That is cysteine. Am I clear, guys?